All right, thank you so much for joining us today. We're now going to go through inducers and inhibitors. We did the foundation already of pharmacokinetics, dynamics, and genomics. Now, that was the layman's term of teaching it when I came up with traffic jam and no traffic jam and tried to talk about constipation and diarrhea. If you don't know what I'm talking about, or tap water like faucet that is just dropping out and keep flowing and flowing, all those small ways to remember it is great for you to be able to connect it with real life. Dr. Kehinde Elisha speaking here, founder and CEO of FNP Certification Academy. At this time, we're going to go ahead and go through the actual content of inducers and inhibitors in family medicine. We all know that this came from where? Pharmacokinetics, and we have three processes in pharm, three main ones at least: pharmacokinetics, pharmacodynamics, and pharmacogenomics. Now, under pharmacokinetics is where we have the ADME process, that is the absorption, the distribution, metabolism, and excretion. Now, under metabolism, we're going to say, okay, there is an enzyme in there that is called the CYP450. That CYP450, we're going to call it what? We're going to call it a truck or a car. So during this movement of the admin process, the car may crash. When it crashes, it's going to emit two things. It is either going to induce or inhibit the process of our drug. So whenever we take a medication, the medication can either pile up in our body leading to toxicity, or the medication will just not work, period. All right? So now let's talk about the different categories that we have here. So first of all, we have the inducers of carbamazepine, rifampin, phenytoin, St. and so on and so forth. So what is the effect of these inducer drugs? So for example, now it is going to effect that's going to supposed to increase the metabolism of other drugs, or another way of saying that is that it is going to speed up the metabolism of the other drug, or another way to also say that is it is in fact going to decrease the efficacy of other drugs. So be familiar with all those terms as well, because whether it's increasing or decreasing will determine how we titrate our drugs, will determine where we move that drug, which direction the drug goes. And the mechanism is going to be what? The CYP3A4 inducer. I promise I am not overdoing this. This concept will be on the exam, and you don't have to, you're not going to be acting like you've never heard of it. You should know it. Maybe you don't have to know it 100%, but you should know it at least 75%. Understand it. It is also something that we're going to be doing for our patients to keep them safe, right? We have to know when to go down on a drug. We have to know when to go up on a drug. We have to know when to discontinue a drug or switch drug to another drug that is not under inducer or inhibitor, or that will not significantly affect our drug that we are given. So what is the clinical implication of carbamazepine being an inducer? It will decrease the levels of, for example, warfarin, OCPs, statins, so leading to therapy failure, right? It is going to what? It is not going to be efficacious. So what is the mnemonic? CRAPS, GPS. C is going to be carbamazepine. The second drug here is rifampin. What is rifampin going to do? Rifampin is going to increase clearance of drugs. For example, it falls under the enzyme what? CYP3A4 inducer. What does that mean? It is in fact going to decrease the efficacy of HIV meds, OCPs, and anticoagulant. R for rifampin. What about another inducer? Is going to be phenytoin. It's going to increase the drug metabolism. What does that mean? The drug is going to get out of the body very, very fast, making it less efficacious. When combined with warfarin, for example, and corticosteroids, it is in fact going to diminish their efficacy. And it's metabolized by what? The CYP3A4 inducer. And what about St. John's wort? It happened to be a natural inducer. Whenever you see St. John's wort on the exam is trying to draw your attention to St. John's wort being an inducer. To induce is to reduce. So we combine St. John's wort with SSRIs, SNRIs, OCPs, and digoxin. Guess what? It is in fact going to diminish its efficacy. So you got to watch out in depression cases. In depressed patients, for example, we should know that when we think that the treatment is failing, that's when you want to go ahead and assess your patient further to make sure that something is not stopping the medication from working like it should. What about phenobarbital? Phenobarbital is a sedative, can definitely, is a sedative agent to start with, can definitely decrease the effectiveness of antibiotics, effectiveness of statins, OCP. So imagine somebody on antibiotics and also on phenobarb, and as clinician, we're not paying attention. So guess what? The patient may die from mega infection just because there is another drug on board that is diminishing the efficacy of the antibiotics. So we have to pay attention to know to go up on that dose so that we can get something good from the drug. It's rarely used usually in family medicine pretty much, but it's just good to know what it is or what the interaction is. That's not something you're going to give in outpatient clinic. Now, smoking, cigarette smoking. All of our patient population do smoke. Cigarette smoking happen to be what? A CYP1A2 inducer. To induce is to reduce, and it will decrease the level of clozapine, olanzapine, and theophylline. Smoking increases metabolism. Let's keep in mind that when it increases metabolism, that means it's going to stop or slow down the drug from working like it should. Now we're going to talk about inhibitors. With inhibitors, we have erythromycin, clarithromycin, grapefruit juice, or even grapefruit, fluoxetine, paroxetine, cimetidine, amiodarone, ketoconazole, itraconazole, TMX, SMX, which is sulfur drug. These are mostly what the inhibitors that we see in family medicine. This is not all inclusive. This is just a lot of the ones that we see in medicine, right? So now with erythromycin or clarithromycin, when combined with warfarin or theophylline or carbamazepine, it is in fact going to increase the level of this drug, leading to toxicity. And that's what I was trying to tell you, that listen, when you do have a drug in front of you, pay attention to the drug on the exam. Identify if there is an inhibitor. If there is an inhibitor, you want to deal with that first, because like we said initially, or in the previous content that we went over, inhibitor is the one that will kill you fast. Inducer will just not let the drug work, but inhibitor will kill you fast. So whenever you see this erythromycin question, grapefruit question, honestly, they are trying to draw your attention to, do you even recognize that we have an inhibitor in the house? And do you know how to actually titrate the medication? So now, when we combine erythromycin with warfarin, theophylline, carbamazepine, what do we see? We're going to see what? Increased level of these drugs, and guess what's going to lead to what? It's going to lead to toxicity. Dr. Kehinde Elisha speaking here, CEO and founder of NP Certification Academy, www.npcertificationacademy.com. Now, the mnemonic that you may want to apply is GPAC-man. I do not like mnemonics. To me, that is extra studying right there. I rather reinforce and reinforce and reinforce. The next thing we're going to be talking about right here is grapefruit juice. With grapefruit juice, we know it's a CYP3A4 inhibitor. They will likely use this concept on the exam. You don't need to worry about it that much. Just understand how it really works. Whenever we combine grapefruit juice with statins, or even grapefruit itself with statin like simvastatin, like calcium channel blockers, we know we can get the patient into trouble. Patient can potentially have what? Rhabdomyolysis, because the level of simvastatin is going to go up to a toxic dose. Inhibitor will inhibit drug. It's going to push the level of drugs up. Does it make sense now? It is going to slow down the drug metabolism, making the drug pile up in our system. Inhibitor is synonymous to constipation. Inducer is synonymous to diarrhea. So with inducer, the drug is leaving the body really fast because of the presence of an inducer. With inhibitor, the drug is staying in the body because of constipation. If you're constipated, are you going to keep eating? No, you want to slow down what you're eating so that it can go before you put something else in, because you're going to get more constipated if you continue to pile it in. All right. You have to have this understanding so that when you see a question, you will recognize exactly what they are asking you so that you can tackle the exam well. If you don't even understand the question and you can't link it to inducers and inhibitors, how do you know what the form question is asking to start with? With inhibitor, when we have, like for example, with fluoxetine and paroxetine, they are mostly inhibitors. And then when we combine with SSRI, guess what? We're gonna see increase in dose in drug level, and it can lead to all kind of problems. In addition to that, too, when we combine with like let me say metoprolol, it's gonna raise it up. You know what I'm saying? It's gonna increase the efficacy of that drug. So we need to keep in mind how inhibitor works. Again, the chemical that we combine with it also matters. So inhibitor can function differently with one drug, and it can also function differently with another drug. At the end of the day, we are mixing chemical together, so we may see different interactions. What about cimetidine? It's an H2 blocker, and it can inhibit the CYP1A2, CYP2D6, and CYP3A4. So what does that mean now? So now we can definitely, when we combine with warfarin, what is it going to do? Because it's an inhibitor, it can increase warfarin and phenytoin level. And, because of that, we don't use cimetidine too much because of this drug-drug interaction that it creates. What about amiodarone? It's an antiarrhythmic drug. It's a CYP3A4 and 2C9 inhibitor. Okay, that's just the enzyme class it falls under. When we combine with digoxin, warfarin, statins, it is in fact going to increase the dose, to toxic level. All right. What about ketoconazole? Ketoconazole happens to be an antifungal. When we combine with statins, QT prolonging drugs, it is going to create a problem, right? It's going to raise up the level, probably prolonging QT faster and even worse than we expect. And then we have the last one on the list right here, sulfur drug, TMP, SMX. It is definitely an inhibitor. It's going to increase warfarin. It's going to increase INR. And then, of course, what do we use it for? It's commonly used for UTIs. We still use it. Don't get me wrong now. You can't be running from inhibitors. You can't be running from inducers. Most drugs always have some kind of interaction that they create, okay? What you're going to do as a provider is recognize it, pay attention to it, know what that drug is, and know how to titrate accordingly. So what is the key primary care drug interactions? Don't forget, when we have warfarin, when we mix with fluconazole, erythromycin, sulfur, we're going to have increase in INR. Bleeding risk is the problem that will result. So INR needs to be monitored closely. See, INR needs to be monitored closely. It doesn't mean that you won't do those drugs together, but you got to monitor INRs closely. What about OCPs with rifampin, carbamazepine, St. John's wort? You know it's going to decrease contraceptive effect and, of course, increase pregnancy risk, of course, right? So you got to use a backup contraception to make sure that you don't get pregnant, or we don't get our patients pregnant when they don't intend to get pregnant. Now, what about simvastatin? With simvastatin, when we combine with grapefruit juice, amiodarone, it's going to increase risk of myopathy, rhabdomyolysis. You want to use pravastatin or rosuvastatin. What about theophylline? Theophylline with ciprofloxacin or smoking. It can increase cipro level and it can decrease with smoking. So it depends on what we're combining it with. See what I'm saying now? It can potentially increase with cipro, but it's gonna decrease with smoking, because smoking happens to be what? A CYP450 inducer. To induce is to reduce. Inhibitor is like eye weight and eye problem, and that will in fact raise the level of the drugs up. Ciprofloxacin happens to be an inhibitor. It's in fact going to increase my theophylline up. So you're going to adjust the dose and monitor accordingly. Our SSRIs, when combined with tramadol, we're going to see an increase in risk of serotonin syndrome. Use alternatives to monitor very, very closely. Now, let's look at this mnemonic. Mnemonic is not all-inclusive. It is just what is commonly and frequently tested. The very first mnemonic is the CRAB GPS for inducers. Carbamazepine, rifampin, alcohol, phenytoin, grisoflovin, phenobarbital, sulfonylureas. What about G-Pacman for inhibitors? Grapefruit protease inhibitors, azole antifungals, cimetidine macrolides, amiodarone, non-DHP-CCBs. Okay. Now let's go ahead and take a look quickly at the questions and answers to follow. But do we have any questions at this time? All right, so let's take a look at these questions and answers and see or how we can apply it. So let's take a look at rifampin and oral contraceptive failure, for example. What will make it fail? So let's take a scenario of vignette with a 24-year-old. So a 24-year-old woman who is being treated for latent tuberculosis with rifampin. She is currently taking a combined oral contraceptive pill, ethinyl estradiol plus norethindrone, pretty much contraceptive. What is the most appropriate counseling point for this patient? A, you may experience weight gain, but your contraceptive efficacy is not affected. B, rifampin may decrease the effectiveness of your birth control. Use backup contraception. C, the interaction only occurs with progestin-only pills, not combined pills. D, you should stop your TB medication if you plan to stay on birth control. Please drop your answer in the chat. Well, you don't need to drop your answer in the chat. I'm used to doing that. Your answer is right here. But maybe we should make it interactive. If you don't mind your voice showing, I can make it interactive. Because you have the answers already, so I didn't cover up the answers. But why do we think the answer is correct? B. Why do we think it is B? All right, so the breakdown of this is very straightforward. How should you approach this question if you see it on the exam? You want to first of all identify what drugs do we have here. So we have rifampin. We have oral contraceptives. Now with rifampin, with rifampin, what does it fall under? It is a CYP450 inducer, or it is CYP3A4 inducer, to say that, especially 3A4. It can also induce other in other areas, but 3A4 especially. So oral contraceptive is also the second drug in here, and that is a birth control. That kind of fall under substrate, or at times it is a very, very weak inducer. So now, whenever we have an inducer with a regular substrate or a weaker type of an inducer, the other inducer will superimpose its effect on it. Now, inducer will not reduce itself. So rifampin cannot reduce itself. Rifampin will reduce the drug that we mix with it. So we are mixing oral contraceptive with inducer, which is rifampin. It is therefore going to do what? It's going to now exercise its characteristic on that other drug, which is oral contraceptive. It is going to diminish the efficacy of that oral contraceptive, and therefore patients will get pregnant unintended. To prevent this, we have to do a backup plan. So B is the final answer here for that reason, and the rationale here, we're going to read it out. Rifampin is a strong CYP inducer, 450 inducer, especially CYP3A4, which increases the metabolism. Don't forget, the word increase and decrease are used in different ways. So this one is going to increase the metabolism, but it's going to decrease the efficacy. Am I making sense? So increased metabolism of the estrogen and progesterone, that means that it's going to leave the body very fast. It's going to break it down very fast. Okay? Now, it's now going to decrease contraceptive effectiveness because it is leaving the body very fast. Because it has an increased metabolism, it has a decreased efficacy. Does that make sense? So when you're seeing the word increase or decrease, see what follows it. See the full definition of it. Now, patients should be counseled to use alternative backup contraceptive. Stopping TB therapy is not recommended without providers' oversight. Let's take the next clinical simulation here, or let's walk through the second question. Again, the answers are not covered because you have the slides, but we're going to walk through why it is so we can have a better understanding, and we're going to have more quizzes in Canvas for you to practice more of these questions. Question 2. It's a 45-year-old male with schizophrenia stabilized on olanzapine. 10 milligram daily. Report he has resumed smoking after 6 months of abstinence. Which of the following is the most likely consequence of this behavior? A. Increase olanzapine levels and sedation. B. Decrease olanzapine levels and worsening psychotic symptoms. C. No change in olanzapine levels. D. Smoking decreases absorption of olanzapine in the stomach. So we got to understand that, first of all, you may not recognize it, but you have to recognize smoking as a drug. Recognize grapefruit and grapefruit juice as a drug, right? Technically, because they have an effect on the drugs that we take. So what is smoking then? Cigarette smoking is a CYP1A2 inducer. So I always say, okay, olanzapine, obesity. By the way, olanzapine will cause a lot of metabolic problems. It's one of our atypical antipsychotic. So olanzapine is the second drug that we can see in here. And guess what? The interaction of a strong inducer with olanzapine is, guess what? It is in fact going to diminish the level of olanzapine. So you're actually prescribing olanzapine to support your patient with psych issues. So psych issue. And now you realize you're not getting any result. Guess why you're not getting results? You're not getting results mainly because the cigarette smoking is in fact diminishing the efficacy of olanzapine. So you're going to still be seeing the psychotic symptom. So you will see that you're not getting anywhere. So let's read the rationale. Smoking induces the CYP1A2, which increases the metabolism of olanzapine and clozapine. Now, this lowers drug levels, risking relapse and psychiatric symptoms. It is important to reassess dosage needs when patients start to or stop smoking. Let's take a look at the third question here. I hope that makes sense. If you have any questions, please let me know. All I'm doing is trying to tear this apart for you so you can understand it instead of giving you the questions to just go do on your own, which I did like last week or so. But I'm not sure how many people really understand what's going on. So I decided to break it down for you. The next question, a patient with depression and hypertension is taking fluoxetine and metoprolol. What is the possible drug interaction and clinical implication? A. Fluoxetine will induce CYP2D6, reducing metoprolol levels. B. Fluoxetine inhibits CYP2D6, increasing metoprolol levels and bradycardia. C. There is no interaction between fluoxetine and beta blockers. D. Fluoxetine increases blood pressure when combined with beta blockers. We know the final answer here is B, but why is that? It is only so mainly because we understand that fluoxetine in fact is an inhibitor, and when we combine an inhibitor with, for example, metoprolol that happen to be a substrate, it is in fact going to raise it up. It is either a substrate or an inducer, but we know that metoprolol in fact is not an inhibitor, right? It is not, and we know if it could be an inducer and it could be a substrate, but we recognize an inhibitor already, and I'm fine with that. Once you recognize one inhibitor, you're going to fly with it. Does it make sense? So my inhibitor in this case is fluoxetine, which is very, very common to be an inhibitor. So now we have fluoxetine now to be an inhibitor. It's now going to raise up my metoprolol dose. If I give like 5 milligram, now it's taking it up to 15 milligram, creating a major problem. Guess what? We're going to see hypotension. We're going to see bradycardia. This is why it is important to monitor these things whenever we combine it together. Let's take a look at the rationale. Fluoxetine inhibits what the CYP2D6 and an enzyme responsible for metabolizing metoprolol. This now leads to higher levels of metoprolol, causing bradycardia, hypotension. Monitor heart rate or consider switching to sertraline, which is an alternative, which is a less, it causes less interaction. Now let's take a look at question number 4 here. Erythromycin and theophylline is the focus of this question. So a patient with COPD on theophylline is prescribed erythromycin for respiratory infection. Which adverse effects should the provider be most concerned about? A. Decreased theophylline levels leading to poor symptom control. B. Increased theophylline levels and risk of toxicity. C. Increased effectiveness of erythromycin. D. Reduced antibiotic efficacy due to enzyme induction. So we know the final answer here again is of course B. But then that is from the recognition of what we have laid on our face here. Recognizing that erythromycin in fact is an inhibitor, and recognizing that an inhibitor will do what? Will increase the theophylline level, will increase the dose of any kind of substrate or inducer that they blend with it. So in this case, erythromycin is a strong inhibitor. It will now decrease metabolism of theophylline. If it decreases metabolism of theophylline, it is the same thing as saying what? It is the same thing as saying that it's going to increase theophylline drug in the body. So that's where I think students will likely stumble when they see decrease or increase. So what are we increasing? What are we decreasing? What is increasing? What is decreasing? So what I'm saying now. So decreased metabolism of theophylline is synonymous, or is AKA what? Increase what? Drug level in the body. Right? Now a narrow therapeutic index, and then of course, what does that mean now? We're going to now see the side effect of theophylline, because we're going to get the theophylline toxicity like nausea, seizures, or arrhythmias. All right. So what can we do in this case? We're likely going to switch to azithromycin. Now, azithromycin also happens to be a macrolide. So we got to know our drugs and class. There is no kid without a mom. For every drug, there is a class. So now if you know that your drugs and class, and you know another drug that belongs to that class, macrolide, azithromycin belong to the same class as erythromycin. But azithromycin is in fact not an inhibitor. It is just a substrate, does not cause any drug-drug interactions with theophylline. So we're going to switch to that as an alternative. All right, amiodarone and warfarin. A 70-year-old male with atrial fibrillation is started on amiodarone while continuing warfarin therapy. What adjustment would the provider make? A. Discontinue warfarin and switch to aspirin. B. Monitor INR more frequently and consider reducing warfarin dose. C. Increase warfarin dose to counteract amiodarone. D. Add clopidogrel to warfarin to prevent clot formation. Now, many students don't understand when they get this question that it has to be an inducer or inhibitor question. So if you don't have that background information, you'll just find yourself guessing out of this question. And half of the time when we guess wrong. No strategy without content, absolutely none. Dr. Kehinde Elisha speaking here, CEO and founder of MP Certification Academy. We offer FNP, AGNP, AGACNP, NCLEX, as well as PMHNP exam review, and that is ANCC and AANP. And we also focus on AACN for acute care. So now, if you understand where your question is coming from, you have a background information, you cannot go wrong. So, of course, we know what the answer is here, but let's go ahead and break it down just like we did others. So, what is amiodarone here? Amiodarone happens to be an inhibitor. Okay? If amiodarone is an inhibitor, as soon as you spot an inhibitor in the house, you should automatically assume the effect that is it is going to superimpose its characteristic on the other things. So, amiodarone is more like the father. The father is supposed to raise things up. So, it's going to raise things up when we mix those things with it. So, it is going to raise warfarin level up. So, amiodarone is an inhibitor. What? It inhibits what? The CYP2C9, and of course, which metabolizes what? Warfarin, leading to increased INR and bleeding risk. It has a very strong half-life, so it affects what? So effects are prolonged. Reduce warfarin dose by 30 to 50% and monitor INR closely upon starting amiodarone. That will be based on your knowledge. That will be based on what you know. You got to understand the content. We are content heavy in our review. www.npcertificationacademy.com. That is www.npcertificationacademy.com, or email nurse-to-nursecoach@gmail.com. We're now going to go to question number 6. It's a 38-year-old female with mild depression is taking fluoxetine 20 mg daily. She begins using over-the-counter St. John's wort. What is the most significant risk associated with this combination? A. Liver toxicity. B. QT prolongation. C. Serotonin syndrome. D. Seizures. We know this is going to be serotonin syndrome. Why is that? Because we're combining what? Fluoxetine with St. John's wort. Listen, I do know that St. John's wort and SSRI combined together already can definitely do what? Can cause serotonin syndrome. So that will be the focus of this question here, to be honest. It is not too much of an inducer and inhibitor, but it also plays a part in it. Because look, additionally, St. John's wort will induce the CYP3A4. It will now reduce the levels of other drugs, so we have to stop and avoid combining both. So now, what about fluconazole and diabetic medication? This is about a patient with type 2 diabetes on glipizide. It's prescribed fluconazole for vaginal candidiasis, which is a fungal infection. What should the provider monitor closely? A. Signs of hyperglycemia. B. Liver enzymes due to glipizide. C. Blood glucose due to hypoglycemia risk. D. Kidney function only. We know the answer is C. We know what the answer is, but why is the answer so? Don't forget, you're going to come to the question, identify which one. Not for every question, of course. All your exam is not going to be about inducers and inhibitors, but when you see them, because you've been exposed to it, you're going to recognize it. So now, here I recognize that, okay, I have a drug here, it's called fluconazole. I also have glipizide here, but I recognize my fluconazole to be an antifungal and is in fact an inhibitor. If it is an inhibitor, it's going to raise the other drug up. It is going to metabolize sulfonylureas like glipizide, and of course, the interaction will cause what? Prolonged hypoglycemia. Because now we're going to give them, due to the presence of fluconazole, you'll be giving more anti-diabetic drug than you really want to. Because that drug, fluconazole, is going to have the effect on sulfonylureas like glipizide. It is going to raise the level of drug up, and it's going to build it up in the system. Now you have more glipizide in your body than you want, leading to hypoglycemia. So you have to educate the patient about symptoms like sweating, dizziness, confusion. That is not to say we're not going to give the fluconazole, but we got to monitor for stuff as providers. Don't forget, you are no longer an RN. You are no longer, if you are LPN, you are not there. You are now an APRN. Don't forget, as an LPN, the examining body is going to ask you, do you know where the pulse is located? As an RN, they're going to ask, do you know where the pulse is located, and do you know how to palpate it? As an APRN, do you know where the pulse is located? Do you know how to palpate it? When you palpate it, do you know when something goes wrong? When you see that something is wrong, do you know how to fix it? That takes you to another level. That level you must also be for your exam. Let's look at question number 8. It's about a 58-year-old female with type 2 diabetes. He started on ketoconazole for a fungal infection. She is taking ripaglinide for glucose control. What side effect is most likely to occur? A. Hyperglycemia. B. Hypoglycemia. C. Diabetic ketoacidosis. D. Interaction no interaction is expected. We should know here that the final answer, of course, is B. And again, based on the explanation of ketoconazole in fact is a strong CYP3A4 inhibitor. It is in fact going to increase what? Repaglinide levels, leading to hypoglycemia. So you got to monitor the blood glucose very, very closely. These are decisions that we have to make as a PRN in real life. Question number 9. A 42-year-old patient with panic disorder is currently stable on alprazolam, Xanax. He is currently diagnosed with what? Community-acquired pneumonia and is prescribed clarithromycin. 2 days later, the patient complains of excessive drowsiness, confusion, and slurred speech. What is the most likely cause of this patient's symptoms? So, all right, so is it A, normal interaction between alprazolam and pneumonia? B, clarithromycin is a CYP450 inducer and reduced alprazolam's level. C, clarithromycin is a CYP450 inhibitor and increased alprazolam level. D, the patient has developed tolerance to alprazolam. Don't forget, there is a foundation for everything we're doing here. If you don't have the foundation, it's not going to take you anywhere. The foundation is that you got to understand your pharmacokinetics, dynamics, and genomics. You must understand where the CYP inhibitor and inducer come from. Once you now understand, there is a list of drugs that I gave to you already in class that you must understand. The list of drugs that you have I have two sets actually, 2 different sets. For inducers, for inhibitors, for inducers and inhibitors. Once you now have that memorized, every time you sit on the exam, you'll be able to recognize it and make the right decision. The final answer here, we know is clarithromycin is a CYP450 inhibitor. That's because we know and learned it initially that clarithromycin and erythromycins are inhibitors, and in fact they will increase the level of stuff. So we're going to be increase the level of alprazolam here, which is very, very risky because alprazolam happens to be what class of drug? Type in the chat for me. What class is alprazolam? All right, so we know that this is a benzo based on, of course, the classification of the drug and stuff. So now, what are the clinical pros that we must have and understand as providers? Don't forget, when you put macrolide with warfarin, it's going to cause increased INR. It's going to lead to bleeding. You got to use azithromycin or monitor INR very, very closely. What if you have phenytoin with OCP? You're going to see a decreased contraceptive effect. You got to recommend a backup method. What about smoking plus theophylline? Decreased drug level leading to asthma or relapse. Then you're going to increase the dose or advise smoking cessation. What if you combine ketoconazole with statins? We're going to see increased statin levels, and then it might lead to myopathy. You got to avoid this combination. That is it for me. Dr. Kehinde Elisha speaking here, founder and CEO of FNP Certification Academy. There is no strategy without content. We got to have the content. We are content heavy, then question and answer follows. This is nothing. This is just the tip of the iceberg. We do have 8 weeks review, and we look forward to seeing you in our review. Visit www.npcertificationacademy.com. That is www.npcertificationacademy.com. After you pass your board exam, you can visit www.confidentprescriber.com to sign up for our expert classes so you can continue to be a better provider. So we do have 99.9% pass rate. We offer PMHNP, FNP, AGNP, AGACNP, and NCLEX exam review, and we're looking forward to expanding. Come join our circle of exam success. We also have a circle of community where if you get stuck with any kind of clinical decision making, we all talk through it together as a group every Thursday night for now. I am doing this video right now, July 31st at 10:48 a.m. Eastern Time. So we really look forward to having you in our review. I really hope that you've enjoyed learning this. Please make sure that you come in for deeper content. This is just a taste of pharmacology. We have food-drug interaction, drug-drug interaction, drug-disease interactions. This is just one of the interactions, the CYP450 system interaction. Have a wonderful day, everybody, and please go visit our website to sign up and learn from the best. Thank you.